Welcome back from the break, everyone. We're going to get started again. I'd like you all to help me welcome Dr. Brett Moran. Dr. Moran is the Chief Medical Information Officer and Associate Chief Medical Officer for Parkland Health and Hospital System, as well as a Professor of Internal Medicine for the University of Texas Southwestern Medical Center. In his role at Parkland, Dr. Moran acts as facilitator and intermediary between the faculty and information technology, promoting information technology to help improve patient care, patient safety, and physician efficiency. Dr. Moran received a bachelor's degree from Texas A&M University. He completed his Doctor of Medicine degree and internal medicine residency at the University of Texas Southwestern Medical Center. His research role includes serving as the principal investigator for a multi-center study assessing the efficacy and safety of oral treatment of bacterial community-acquired pneumonia in adults. His primary clinical areas of interest include medical informatics, preventative health, and pneumonia. Join me as I welcome Dr. Brett Moran, presenting on the advancements of telehealth. Welcome, Dr. Moran.
Thank you for having me, and I'm really pleased to be able to talk about virtual care in the 21st century. And I'd like to start a little bit in the past. I don't know if anybody can recognize this. This was the original Parkland from 1898. And I want to start here because virtual care is truly an evolution of medicine, because we've evolved from the horse-drawn buggy in the days of sulfur powder to treating infections, from the days of leeches, although we still do use leeches a little bit. But we have evolved from the days of the past to moving forward. And this is one of those examples. This is the second Parkland Hospital, the one that many of you remember, the one that I grew up in. This was built in 1954. Virtual care comes in handy for Texas as we talk about this.
So again, virtual care, this is the old hospital from 1954, and virtual care comes in handy for Texas because of its vast size. There are 160 rural hospitals that are serving 12% of Texans by population, but they cover emergency and local services for 85% of the state's geography. There are 185 Texas counties that lack a single psychiatrist, meaning over 3 million people lack practical access to behavioral health care. And so virtual care is one of the solutions that can really help these kind of situations and can provide significant benefits to people who have difficulty traveling for a variety of reasons. This is just a slide to kind of simply state what is virtual care. And virtual care is a broad term. It encompasses all the ways healthcare providers remotely interact with their patients. In addition to treating patients via telemedicine, providers can use live video, audio, instant messaging, and other ways to communicate with patients remotely, both in real time and also what we call asynchronously, where they can talk to them back and forth over emails or secure messaging. Virtual care encompasses all aspects of care, so it's not just video visits, but it could be telephone visits. It's anything that's outside the four walls of a clinic visit. It could be secure messaging or email. And it can also be between the patients and their doctor, or between the patients and a specialist, or between the doctor and a specialist, and back and forth. And so all of these are opportunities for virtual care to occur instead of making the patient bounce between clinic to clinic and drive and park and deal with registration and waiting and things like that. Some of the benefits of virtual care: it can satisfy what we call the quadruple aim. The quadruple aim includes improved quality of care and patient experience. By having virtual care, a lot of patients are much more satisfied. It's an easier experience. They don't have to do as much travel. It may even be more affordable. It can improve the provider well-being. A lot of physicians say that they feel better when they're doing virtual care. It's actually something that's more enjoyable for them. There may be lower cost of care, and it may improve overall population health. It may actually remove some bottlenecks because we can take care of more patients in a more rapid manner this way. Interestingly, 25% of Texans surveyed said they first learned about virtual healthcare services following the COVID outbreak. And about 4.5 million Texans started using telehealth or virtual care services since the pandemic began. Other benefits of virtual care include access. As you can see, there are several graphs here. This one here shows the significant rising rate of poverty in Dallas itself, going from a low of 12% of people living in poverty up to a high of 20% in 2010. You can see a significant amount of people living in poverty in Dallas and various counties. You can see the rate of growth of that. And you can also see that in the US, 12% of people are unable to see a doctor due to cost, whereas here in Texas, it's almost 17%. There's also a risk of virtual care, which is access to technology. And this is a map showing Dallas County houses with at least one internet-connected device in the household. And the darker areas are the places that have more, and the lighter places are the ones who have less internet-connected devices. This is a graphic that I like to show. At Parkland, treating illness is something we really do well. And we have a level 1 trauma center. We have a variety of centers of excellence. We're very good at treating ailments. What's more difficult, however, is promoting and maintaining wellness. And while 95% of the $3.5 trillion of national healthcare expenditures are spent on downstream healthcare expenses, it only impacts about 20% of a person's health. Contrastingly, only 4% of national health expenditure is focused on upstream expenses such as healthy behaviors, socioeconomic factors, alleviating disparities, and this impacts 80% of the health outcomes. So there must be a change in how healthcare approaches patient care. The old practice of periodic visits within the four walls of a clinic and a one-on-one engagement with a doctor have value, but that can't be the only engagement. By 2030, more than 20% of Texas population will be over 60. In the next 10 years, there'll be an estimated increase by 50% of the Texans aged 85 years or older. Combining that with the progression in percent of individuals living in poverty, and one has a large group of Texans who have transportation, mobility, financial issues, and that leads to failing health and the system that's failed them. So I want to now pivot and talk about Parkland and virtual care at Parkland Hospital. So we began our journey in 2012. It's been a slow journey, and we had some initial concerns about whether the patients actually wanted virtual care, and that was unnecessary. The patients do want virtual care, and they actually like it. We had some concerns, which were incorrect, that our patients may not have the capability of having virtual care. And again, that's something where almost everybody has a phone. Not everybody has video, not everybody can do video, but you don't have to have video capabilities to have a virtual care visit. So we began with brief visits, and then we expanded to what we call electronic consultations. And I'll talk more about that in just a minute. And you can see how our journey began, where we had no virtual visits. By 2012, we had a little over 2,000. And then it has incrementally increased, and then something happened this year, which I don't have to tell you what that was. The first part of virtual care at Parkland that I'd like to talk about is electronic consultations. And this is a solution that helps shorten the time to getting the expert specialty opinion. And this is one of those communications I was talking about earlier that is actually between your primary care doctor and the specialist. So rather than them send you and have you make an appointment and wait to see a doctor, they send an electronic consultation. And you don't have to go anywhere, and the doctors consult each other, and you get the care that you need. So we began this with dermatology. We began it with them back in 2014 because they were getting about 5,000 new referrals per year, and they were having a difficult time keeping up. And you can see how many projected number of visits they were having, and these are current and new referrals. And you can see the follow-up appointment days, how long it was taking for someone. Some patients had to wait more than a year to get a new appointment at one point. We fixed that, but they were still having to wait a couple months at one point and then over a month to get an appointment with a doctor. And that, of course, was not acceptable. Their annual visits were 14,000, and they were going to be rising, and they needed to do something about it. This was the standard process. If a doctor refers you to a specialist, the doctor has to talk to you, then they put in an order. It gets sent over to the specialty clinic. They have to call you. You have to call them. There's some phone tag. An appointment is made. And then a long wait. And then you get to see them. And then they decide you really didn't need to be seen, and that was a wasted visit for you and them. Or they say, you're pretty sick. We need to see you frequently. Or they say, we're going to make some recommendations, and you go back to your regular doctor and call us if you have problems. But there are lots of communication gaps. There are gaps in care, and there's time delay. And all of those things can add up to time waiting to get the care that you need. The electronic consult model, on the other hand, allows for the referring provider to craft a question. They post it in our electronic health record, and it goes instantly to the specialty provider, who can review it, review the chart, and then send a response. And they can answer it, and the referral is closed. They can ask for additional information, or they can say, this patient needs to come in person. We need to see them to evaluate them. So for the teledermatology electronic consult program, we actually also added a new functionality where we had the capability where our doctors could take pictures through a special secure encrypted app on their phone. They would send it to the electronic health record and then send it to the dermatologist. And so we could actually send pictures, submitting it to the dermatology specialty, who would be able to review the photos. So not just someone describing a rash or a lesion, but to be able to see it in person on a high resolution screen with a good photograph. And then they can prescribe the medications that the patient may need. You can see the types of things the teledermatology saw, and they saw a variety of abnormalities, including cancers and precancerous lesions. Compared to their normal in-person clinic visits, there was a lot of comparability, very similar. They did a pilot in 2014 where they followed 79 electronic consultation patients, and they found 65% of them were able to have their problem diagnosed and addressed by the eConsult alone without the patient having to go see a dermatologist. And they passed along recommendations to the primary care doctor, who would then give the patient the medications to help cure or treat their problem. 5 patients were needed to be referred to the clinic and are subsequently referred, and 33% or 33 patients needed to go to the clinic. When you look at the time to evaluation by a dermatologist, for a normal consult in person, it was on average 68 days. For the electronic consult, it was half a day.
Wow.
When you look at time to definitive treatment, for the in-person visit to getting some treatment to help the person with their problem, on average, it was 75 days for traditional in-person visits. For the electronic, it was 17 days, and actually there was one patient that was an outlier. If you look at the median, it was actually 3 days. So 3 days versus 73 days to getting definitive treatment. And you could see that the vast majority of patients had long-term improvement. When you followed them for follow-up, over 715 eConsults have been completed by dermatology, with almost 95% of them completed within 3 business days. And the vast majority of them are managed by their primary care doctor, and their symptoms are better. And for the small percent that aren't getting better, they can go and be referred to dermatology. So we're left with kind of a tale of 2 cases. With a direct in-person clinic specialty referral, it may take months versus days for an electronic consult. For time to appropriate intervention, it could take months or even a year versus weeks or days for an electronic consult. And for the patient, for in-person clinic referrals, they may have to drive and park and get validation of a parking ticket and sign in and register and wait for a minimum of 2 or more visits before they get definitive treatment. Or for an electronic consult, they can stay at home and enjoy their comfort of their home and the things that they're normally doing. So for our electronic consults, currently over 6.5% of all of our consultations at Parkland are electronic consults. And we've had over 16,000 completed consultations since this began, and about 4,000 per year. And the average day to completing a consult by a specialist is about 2.5. And you can see the services that we offer, including behavioral health, cardiology, dermatology, diabetes and endocrinology, gastroenterology and liver disease, infectious disease, nerve and blood problems, the lung and rheumatology, and the urology areas. And they're seeing about 400 to 500 electronic consults per week. This has been recognized as a best practice by the Joint Commission, who oversees all medical affiliations across the country. And several of the programs were presented at state and national conferences. We're very pleased with how we've been able to serve our patients in a much more rapid and effective manner using this tool. In about 2012, we also began offering telephone virtual care visits, and that was our beginning of using virtual visits. They were short visits, they were single topic, very directed and tactical, and usually a follow-up nature about blood pressure, diabetes, some type of chronic disease. They were arranged in advance with agreement with the patient and often initiated by the patient. And you can see that we have grown that from just a few thousand to, on average, about 28 to 30,000 per year of these brief 10-minute tactical telephone consultations that we do. About 2017, Parkland started a program called Parkland Connect, and that's our video program. And it offers video or telemedicine visits for primary care issues. Patients can request this through their patient portal, which we call MyChart. It may be offered by a nurse when they're triaging symptoms, and it's ideal for people who have colds or coughs or rashes or some other common symptom. The patient would then use their MyChart. This is a picture of MyChart. They could schedule a Parkland Connect visit, and then when the time for the appointment comes, they can actually click through here to connect to the appointment virtually and in a video fashion. Some of the things that we offer for this Parkland Connect, not only for common ailments, but we're now using this for school-based telemedicine. We're using it for post-discharge follow-ups by pharmacy to make sure people are understanding how to take their medications and making sure they're not having any side effects. We're doing virtual shared medical appointments, which has been really successful, particularly during the COVID pandemic, where we can have classes for smoking cessation, for pain management, for people with depression or anxiety or other behavioral health problems. And it's been very, very successful. And we've also started a pilot of doing this for people who have had a trauma, an accident, an auto accident, or some other trauma to assess them and help them so they don't develop post-traumatic stress disorder. And that's been another big innovation that's been happening. This is to date how we're doing with these Parkland Connect visits, and you can see we're doing about 200 to 250 per month. And you can see how it's grown since October of 2018 when we were doing just a couple dozen. And obviously when the COVID pandemic hit, it quadrupled overnight. And we've been doing big business ever since then. I'd like to pivot and talk a little bit about COVID and Parkland and virtual care. Obviously, as everybody knows, virtual care has become a very big thing that's been enhanced with COVID coming along. And so a quick history of Parkland and COVID. In December of 2019, the first cases of COVID were described in Wuhan, China. And at that time, a cluster of cases of pneumonia was what was described. They didn't even know for sure that it was a novel coronavirus or anything. But at that time, Parkland's disaster management began conversations with their supply chain about personal protective equipment stock because they were thinking ahead. And on January 5th of 2020, the WHO published on a new virus. And in early January of 2020, Parkland's infection prevention began turning on travel screening questions in our EHR to identify if patients had traveled to other countries and had symptoms. By February, our executive leadership began conversations and meetings planning for possibility of COVID coming to North America in Dallas. And by February 28th, Parkland declared a disaster and began preparations for the pandemic. By the beginning of March, Parkland opened a COVID command center. It was staffed around the clock, 24 hours, 7 days a week, to help operationalize management of COVID. And unfortunately, on March 14th, we had our first case of COVID. There were actually 3 cases. and we've been addressing COVID ever since then. On March 25th, we opened we were one of the earlier organizations to actually create a discrete center for managing patients. It was walled off and had negative air pressure, and it was an entire unit for COVID management. We called it our tactical care unit, and you can see some pictures here of that unit. You can also see some of the other innovations that were happening at Parkland, including Parkland helping do community testing with drive-through COVID tests. And Parkland also stood up what's called a chat bot on their website, where you could actually come and do a symptom check by answering some questions on the website to see if you may have a risk of COVID. And if you do, it would then offer to route you to the Parkland nurse line, where they could help assess your symptoms. From a virtual care standpoint, there was a lot of things that we had to do rapidly. We needed something that would help us with basic visual assessment of patients in the hospital. We didn't want people going in and out of the rooms where there was a lot of risk of exposure, and we didn't want them to have to put on the personal protection equipment and take it off every time they need to go in to just check an IV, because the supplies were very precious. And so we came up with one thing which is called the Molly machine, which is a handmade, whatchamacallit kind of robot, which is basically a camera on wheels. And it's we call it Molly because it's a mobile observation and logistic information machine. But basically, it's a wide angle, high definition camera that can pan and tilt, and it has a built-in microphone. And we have it to where it instantly answers on the patient side. And then each device has a unique phone number, and that would allow the nurses and doctors to talk to the patients. It would allow them to look at the patient when they're sleeping and look at their IV, look at their vital signs, look at their ventilator, and things like that, so that they can minimize the number of times they have to go into the room and potentially expose themselves, disturb the patient, and utilize the personal protective equipment. So this was a new thing we created. It was rapidly created and very useful for the team, and it was one of the big wins at that time. The other thing that we used this for was we were able to turn on video chat for the patients as well. So whereas this helped with communication between the patients and the doctors and nurses, we also used a similar technology that would allow the patients and their families to communicate. And we were able to have children from home see their grandmother for the first time in over a month. And a mother with COVID was able to see her baby that she hadn't seen for weeks. While we were in the hospital working on these things, we also began an inpatient electronic consultation program for infectious disease, because so many people had questions about COVID, and it was hard for them to keep up with going to see every patient. And so again, using this electronic consultation format, we were able to expedite decisions about patients from infectious disease. And it was the first time we'd done this on an inpatient setting. We had a new era of telemedicine and video visits with COVID, and we had extensive use in our ICU. And we had a lot of patients who were very sick, and they were on the ventilator, and there were a lot of specialties needing to manage them. And once again, we didn't want to have all of these people coming in and out of the units and potentially exposing themselves and other people to COVID. And so Dr. Matt Levino, our medical director of the ICU at Parkland, began a multidisciplinary virtual round multiple times daily on every patient. And we used, and you can see the picture here, this roving high definition telemedicine cart. And it has a camera on the top, and it has a high definition screen here. And it even has a place where you can keep a virtual stethoscope and some other supplies if you want. And in the room was Dr. Levino, our critical care physician. You had an ICU nurse, you had a nurse anesthetist or an anesthesia person. And then remotely, you would have the specialist, and you may be able to see a little box here. There's two different doctors here, and there's a doctor here. And so you would have the specialist be able to dial in and see the patient and talk to the team, and they would do conversations about how best to manage the patient. And one of the things that was very unique that I really liked was that, and this is right here, you can see they had a palliative care physician on every round to make sure that the patient was being managed in a very compassionate way, that the pain was being addressed, that we were dealing with the mind, body, spirit aspect of the patient care. So we started with about 2 carts. We ended up expanding it to around 8 carts. And you can see there's just another picture of the tactical care unit where they were just everybody in their garbs, everyone around and right in front of them. You can't see, but it's a telemedicine cart with people there. So very big initiative, very exciting. I was able to talk to Dr. Levino one day, and he actually brought me on rounds with a separate cart so I could watch them rounding. It was a very moving experience, and it was very special to see everybody focused on one patient, trying to do the best they could to keep them alive. As you can imagine, when COVID hit, the office visits plummeted. Nobody wanted to go to the doctor, and the doctor, quite frankly, didn't want a lot of people coming in who may have COVID, and so the office visits plummeted. But one of the things that was really interesting was that's when virtual visits took off, and you can see that exactly as the office visit came down, the virtual visit went up, and we dropped office visits by 73%, or 11,000 per week, and our virtual visits went up almost as much as the office visits declined, 19,000 per week, or a 900% increase. There's a lot of numbers here, but the thing to pay attention to is this is week 12. This would be about March 15th. This is when COVID first hit Parkland, and you can see our baseline. We had about 30% virtual visits in our COPCs, our community outpatient primary care clinics. And we were seeing about 8,800 patients a week. Look what happened as we went through the pandemic. We began having more and more and more virtual visits. We had at one point more than 70% of our visits, certainly easily into the 60s as we went through this pandemic. And look at the volumes. Fascinatingly enough, they dropped slightly from 8,800 to 8,600, but then look what happened. 9,100, 8,900, 9,200. We actually maintained 10,000 and grew some business. This is our specialty clinic, and I'll spare you from having to read the small numbers, but it's the same story. Market increase in virtual visits, maintaining or even growing the number of annual or weekly visits in the clinic. So the fascinating and exciting thing was that while a lot of healthcare systems were having significant drops in patients and being able to maintain and follow up with patients, we were lucky in that we scrambled and quickly were able to deploy a simple telephone call virtual visit, and we're able to reach out to people. And in many cases, we were actually able to reach out to people that had not been able to make it to our clinics for prior problems with transportation. So we actually grew our business during COVID. We did have to rapidly deploy the telemedicine, as I described. It was virtually overnight development of it. We had to do massive training, and we had lots of communication, and there were issues. We had lots of problems with phone tag between the patient and the providers. We had issues with interpreters, trying to add them to the equation, and we have a significant number of patients that don't speak English as a primary language. We had to standardize the process. We had medical students and residents and fellows, and we needed to provide supervision virtually as well. There were a lot of things that we needed to do that we had not anticipated. But we stepped up to it, and there were some really interesting and good things that came out of it. This is a screenshot of a study that came out of the Department of OB-GYN at Parkland, and they published it in the Green Journal, which is a very notorious or prestigious journal for OB-GYN, looking at the perspectives of patients who had telephone-only virtual visits for prenatal care. And it showed significant satisfaction, and it showed that they felt that their care was maintained and that their pregnancy was working well, and they didn't have a lot of adverse problems. And again, this was one of those, in a crisis, you have to do what you have to do to take care of the patients, and it worked out very well. This is a screenshot of the ABCs of virtual visit, a document that we sent out to our patients to let them know and to try to teach them more about it, because as I mentioned earlier, a lot of people were doing virtual visits for the first time in their lives. They didn't know what it was, and a lot of doctors were doing virtual visits for the first time in their lives. So we were doing lots of education, and the screenshot here is just a picture of what we tried to build out in our electronic health record to make it easy for the doctors to where they could just almost be cookie cutter with how to document this. So virtual care is doing well. It's alive and well at Parkland. We now have more than 245,000 completed virtual care encounters. And if you look at how many of these people who have virtual care have presented back to the emergency room in 30 days, it's 6%, which is relatively low. And only 1% of them have visited the ER within 48 hours of a virtual care visit. And so we are providing a large chunk of our care through virtual care. Our virtual care department has grown over 72% for some of the programs. The annual growth of our Parkland Connect video visits has grown more than 220%, and we are expanding our services every day. And so we're very excited about where we are with virtual care. But what I'd like to talk about for the remaining few minutes is to talk about where we're going from here and what are the potential opportunities. So here, what do you see? This is a famous painting from 1891. Most of you have seen it before. And what you notice is you see a doctor sitting at the bedside with extensive concern about an ill child. And it looks like there's been a lot of compassion. He's got a cup of coffee or tea there. He's been up all night. He's gazing on at the patient, showing the values of an ideal physician, the inadequacies of the medical profession. You can see the parent in the distance, the shadow, looking on, gazing on at the doctor. What do you see here? So here you see a lot of technology. You see computers, you see scanners, you see artificial intelligence, you see tablets, you see all the technology of the 20th century. But you also see something that looks cold, looks sterile. It's missing what we saw in the last photo. It's missing the human touch. It's missing the person that knows the patient, the doctor that visits their house, that visits their room. It seems a little more cold. So what we're trying to do at Parkland is combine the 19th century medicine aspects that we like with the 20th century technology. And so we take the ideals of the 19th century medical system, where the physician knew the patients and the families well, they knew about the patient, they knew what was important to them, who helped make their decisions, what mattered to them. We merge it with the 20th century medical system with technology, more expansive diagnostic capabilities, better treatments that have never been seen before, more innovative care, and it develops a system that deconstructs the old practice of care of only occurring episodically within the four walls of the doctor's visit, and it re-envisions how to provide care. It's not focused on treating illness, but it's focused on promoting wellness, empowering the patient to take care of themselves within the belief system, and tailored to what's important to them regarding their health. So that's the 21st century patient wellness and empowerment. And so our core mandate at Parkland is to furnish the aid and care to the indigent and the needy patients residing in our county. And at our core, we've dedicated ourselves to providing excellent care, and we're focused on being a high reliable organization. And that's why Parkland was ranked 10th best hospital in the nation by Washington Monthly, which took into effect inclusivity, community benefit, and overall civic leadership. Parkland is participating in the community health needs assessment for the county. We've dedicated resources, manpower, and agenda to identifying and engaging and addressing the community health needs of everybody, but particularly those who have been underserved, unfunded, and have limited access to care. Our goal is to create a virtual care strategy that will care for the most at-risk individuals, and it could be a model for the rest of the state to emulate. And we're dedicated to public health and wellness. So this is what our virtual care, we envision it to be. And it's very busy, but you can see a lot of the things here, such as primary care. You could have virtual visits for nutrition and virtual visits with a pharmacist for medication management. You could have specialty virtual visits. You could have prenatal care. But we could also address behavioral health, people who are having poor disease management, such as diabetics or people with poorly controlled blood pressure. We could do virtual nurse visits for some follow-up of the blood pressure or diabetes. We could do employee care, high risk of readmission, pre-cancer navigation, people that are at risk and we're worried about cancer, we want to navigate and make sure they get checked out. There's a lot of things that we could do with virtual care. Those are the things that we're looking at right now. So this is kind of where we're at with our future vision. We have three parts to it. The first is creating a culture of virtual care strategy. And that is basically helping teach people about what is virtual care and how valuable it is. And that teaching is not just to the patients, but also to the clinical care teams. The second part is a global or enterprise virtual care infrastructure and support. And what that means is basically rolling out the capabilities of having virtual care visits for people so that they can have a video visit if they want, they can have a telephone visit if they want, or if they want to come in person, they can do that. And it's based on what the patient wants and what's best for the patient. And the final strategy is a centralized virtual care department. And that would be a department that is focused and does tactical outreach with patients for certain special needs, such as people with poorly controlled diabetes or people who have health maintenance screening that is out of date, to help get them back in alignment with what they need to do based on what's important to them. So the focus then will shift. We're going to spend a lot of time looking at who is thy patient. We want to know who the patient is. We want to know who you are. What do you feel is important for me, the physician, to know about you? What do you, the patient, want to get out of your health? What is it that you prioritize? What's important to you and why? And who are the important decision makers in your life that help you make those important decisions? That's one of the things we teach in medicine, in medical school, is know thy patient, but it often gets lost in the busy, hectic schedule of the ever-increasing checklist of items that we as primary care physicians are often asked to manage. But we are going to reprioritize getting that information, capturing it in a specific place in the chart so that we can all look at it and make sure we know what's important to you, the patient. We're also going to be looking at what are your needs? What are your medical and health needs? How do we promote wellness proactively and not just treat illness reactively? What are your medical health needs? What are your mental health needs? Have we asked? Have we listened? We're going to look at your social health needs. Do you have a bed, food, electricity? Some people don't have the ability to pay for medicines, and you spend so much time telling them to take their medicines rather than figuring out why they're not. Do they have transportation issues? Are they lonely? What about their virtual care capabilities? Do they have a phone? Do they have a computer? Do they like having video visits or not? And those are the things we need to capture so that we can better suit your needs and provide the things that you want. In fact, 2.5 times more Texans prioritize not getting sick as their top reason for using telehealth, more than convenience, cost, lack of transportation, etc. It's about promoting wellness, and that's what people think is important, and that's what I think is important. So this is just a graphic from Gartner that shows the different use cases of virtual care along one's health journey. And so you can see that virtual care can be used to help manage people aging at home, checking symptoms and doing electronic visits. We could also do health kiosks where people can access health in certain locations, and that's something Parkland has already started to do. Urgent care, teleparamedics, so acute care, virtual triage, even mobile stroke, and that's another thing that Parkland is starting to do. And then post-acute care, after you go home, you could have home health virtually, physical therapy virtually, and then, of course, chronic outpatient management. So the entire health journey can be managed through virtual care, and those are the things that we're looking at Parkland. The last thing I'll talk about as far as the future of Parkland, the last two things, is the Centralized Virtual Care Center. And so I mentioned that in the last slide before this one. So this would be a tactical outreach team, and they would look at groups of patients that are identified based on different needs. So this would be kind of a paradigm shift of how we approach patient care. And we'd be deconstructing the old model of seeing a doctor 2 to 4 times a year. And we would try to do frequent small engagements or check-ins to make sure the patients are doing well. And it wouldn't always be a doctor. It would be different members of the team, maybe a pharmacist, maybe a nurse, maybe a therapist, maybe a nutritionist. And this would allow the patients to empower themselves to help take care of themselves within their belief system, tailored to what's important to them, using the multiple disciplines and brief multiple small feedings like the birds here. So we want to build a virtual care team that proactively addresses patient needs, comprehensively encompassing medical, behavioral, and social needs. It would be centralized, this team. They would be people skilled in outreach and navigation of patients. And the patients would be identified by a variety of means, including through referrals, or we'd be using some different reports or predictive analytics to identify them being at risk for certain things. And the team would have a multimodal approach to reaching out to the patients and figuring out why they're having problems with their disease and to try to address those diseases and to help them with that issue. Remote patient monitoring is another thing we're looking at Parkland. These are tools that will be helping us monitor patients, and many of these things can quote unquote phone home and call in the readings, so you don't have to do anything. You just check your blood pressure, your blood glucose, or your weight, and it will phone home. And those are other things that we're looking at doing within our virtual outreach center. So the final comment is virtual care is a critical tool to enabling and empowering patient wellness, not just at Parkland, but for the state and the nation. And Parkland is well along its journey to bringing live a lot of functionality that's going to help the patients where they live and where they work. We do have limitations. We have difficulty with technology, as everybody does. Some patients don't have broadband. We have some issues with language and interpretation. But we are investing in trying to create a digital front door to re-envisioning a care model that allows us to have multiple small virtual engagements to help a patient on things that is important for them in their wellness journey. Our virtual care is going to be holistic. We're not just looking at the physical, but we're looking at mental, spiritual, and social aspects of their care. So the future is bright at Parkland, and I've really enjoyed having the opportunity to speak to you about virtual care. And I will stop here if there are any questions or comments. Thank you very much.
All right, we do have some questions and comments. Let me pull some of those up. There's quite a few questions about the senior population and their ability to navigate telehealth with their physicians. I know you touched on that briefly, but can you elaborate a little bit for us?
Yeah, we recognize that's a problem. It's not easy using anything that's a new technology. And so what we're trying to do is we're trying to make it easy for people. So one of the things we're doing is to try to do it in a standardized way. So a lot of the healthcare organizations around town use the same electronic health record called Epic, and they all use MyChart. And so we're trying to create our video visits and our virtual care the same way that everybody else does. So if you do it with one place, they'll do it the same way with us. That's one thing we're trying to do. The other thing we're trying to do is to allow people, when they sign in, they can click a button to check and make sure that everything's working on their side. And it'll tell them if there's any issues with their computer or their phone or their audio. And then if there are issues, we're trying to make available a way where they can quickly get to the help desk to help work that out for them. So we do know these things are difficult. And as a last resort, if it has to be converted to a telephone, that's okay. And we've been really emphasizing that. Telephone virtual care is okay. Video is nice. It's nice to see people and to see their face and to speak to them. But telephone is okay too. It's not a failure if you have to do a telephone encounter.
Awesome, thank you. There's quite a few comments essentially saying that they're proud of Parkland and the work that has been done there and the accomplishments of the program that you've got. Another question is, doctors are requesting in-person visits. I worry about that higher risk for COVID. What is your profession doing to educate physicians regarding the value of the virtual visits?
That's a great question. I love whoever asked that. Maybe that was me. You know, we struggle with that, and there are a lot of doctors that are what some may say is old school, and that they like what they're comfortable with, and they prefer the patients being in person. And so you're right, it is and that's why if you remember the iceberg that I showed you, the bottom part, the part that's below the water that you really have to build a foundation for, is that culture. And we really have to get people to understand that. And so there will be a lot of learning, there will be a lot of engagement. The good news is that Dr. Cerise, our CEO, is very supportive of this. And so there will be support from the top down in the importance of doing this. We know this is going to be something that's good for our patients. It also helps with bottlenecks. It helps get care better, faster. and people are more satisfied with it. But it is going to take a little bit of time to get people to come around, and so it's going to be a slow but hopefully steady journey.
So a question I have with regards to your Molly device that you all have come up with and started using is plans for the future for that device. As we know, even just in normal hospital visits, it's really difficult for patients to get the rest that they need because the nursing staff is constantly going in there to check on them. The physicians round at all hours of the day and night. And so I can personally see how this can benefit the healthcare system just in general, helping patients to actually get better care. And so kind of what plans do you have? How many devices do you currently have in place, and what are your plans for the future?
Yeah, that's a great question. We ramped up and we had about 50 devices when we were in the peak of our COVID. We don't have as many. I mean, we have right now, I think today we have 880 something patients in the hospital. So we don't have that many Molly machines, but we are looking at that. And I think that's a great point. Is that's another initiative that we have, which is trying to avoid alerts and alarms that are disturbing the milieu in the environment, all of this noise pollution. And so we are looking at doing things so that people are disturbed less often. And to your point with the Molly machine, if they can peek and check on a patient without having to open the door and go in and turn on the light, and they can just make sure that the IV is doing well, the vital signs are okay, and with this high resolution camera, they can see their breathing. I think that's a very interesting innovation that we should talk about.
Absolutely, absolutely. Another question from one of our attendees are how the eConsults are covered. Are they covered by insurance, or do you all charge for them, or how is that working? Do they have to be advised?
Yeah, I mean, that's a great question. Right now, we have not charged for them. You can, but if you're going to do that, you do have to consult the patient. You have to get their permission, let them know that you're going to do an electronic consult. Are they okay with that, or would they prefer to do an in-person one? For us, we have not done that. We began piloting it. As we expanded and go full-fledged with it, we may consider doing that. But at this point, it's very helpful to us. It's helping with the bottleneck. It's helping with the turnaround, and it's valuable to us even without billing for it.
Next question is, how do you manage the need to listen to a patient's chest, looking in the mouth, etc., using your other senses such as smell that you're not able to do virtually? How are you overcoming those issues?
Yeah, that's a good, so by no means do I or do we advocate that we should get rid of the face-to-face visit. I think that needs to be there. And I'm a believer of even the annual exam. Not that I believe that getting all the labs or doing all of the testing has necessary value, but laying hands on the patient, talking to them, and developing that relationship is very important. And that's what I liked when I had a big primary care practice. I think that was very valuable for my patients and for me. So I do think we still want people to come in once or twice a year. But a lot of the doctor visit, when you think about it, when you go see your doctor for a follow-up visit, usually they ask you, are you taking your medicines? Are you checking your blood pressure? How are your sugars? Are you exercising? They do a kind of perfunctory listening to the heart and lungs, but they don't really need to. They don't need to do it that often. They do it because it's what's been required by our billing system, which is going to change this year. So I think it needs to be a nice mix. I think 50-50 or less in person. I think, at least once a year you should see your doctor in person, and then it just depends on what your problem is. If you do have a condition where you really should be examined, then they need to bring you in person. But there's a lot of things for chronic management that could be handled from a virtual standpoint.
And so you personally see this telehealth having a significant role just in general patient care moving forward? Absolutely.
And as I said, I would love for us, and it's going to be, again, it's a matter of changing the culture. But I think we need to get away from the old model of the only time you see your doctor is maybe 2 or 4 times a year, and otherwise you're on your own, and it's completely, and so 4 30-minute visits a year at most, and that's it. We'd rather do frequent check-ins, using the virtual, using apps, using messaging, How are you doing? How's your blood pressure? How are your sugars? Are you still exercising? What's going on with your weight? Frequent, multiple small check-ins. What can we do to help you? That way we can detect if things are changing much more rapidly and do something about it rather than waiting to see you 6 months later to find out something terrible has been happening.
And what about in areas where the internet coverage and service coverage is maybe not available, or if it is available, it's not very good? Do you feel like using just the telephone for that is sufficient?
Yeah, and that's something we're looking at. So it's interesting. We had more than 280,000 telephone virtual encounters since COVID started. And so that's one of the things I'm studying is I'm trying to look at, did we do okay? How did people's diseases do from telephone only visits? And so I can't answer that question, but at least objectively. Subjectively, the patients feel like they received the care they needed, and they really didn't want to come in and they didn't want to get labs done. We know that certain things fell behind, people coming in to get a colonoscopy or a pap smear. People weren't interested in it, and the procedure labs shut down during the height of the COVID pandemic. And so those things are going to drop a little bit. For the areas that have poor internet, there's two options. One is that there are several free phone services where people who have special needs can get a phone for free from the government. And so we could do a telephone visit. And it's kind of interesting because I was in clinic Tuesday and a resident was checking out to me on a patient that was homeless, and he had done a virtual visit on this homeless patient, and I was surprised. I said, well, he's homeless. How could you be doing a virtual visit? He said, well, I just called him. He has his cell phone. And so you'd be surprised how many people have smartphones out there. So that's one option. The other option is that we have started to deploy kiosks, and we've done it at one site so far, and we're looking at working with the community thought leaders in an area and putting it in libraries or community centers where people can then go and use a kiosk and have a confidential virtual visit with some dividers or partitions. And that's another opportunity that we're looking into.
And then the outcomes that you were talking about that it's hard for you to measure right now, are those currently being studied? Do you have things in place where you're studying some of those outcomes?
Yes, absolutely. In fact, I have a meeting next week with the data team on that. So we are looking at people before and after COVID who just had telephone only virtual visits, and how was their disease? Did it get better? Did it get worse? Was it stable? We're looking at those things, and we hope to be able to advocate if we find that it is equivalent to in-person or video care, because right now telephone only virtual visits are not reimbursed by the government, and they don't get paid for. And so if we find that it is valuable, we want to make sure and pass that along to the state representatives.
Awesome. Thank you so much, Dr. Moran, for your presentation today. I think it was insightful and educational. We really appreciate you taking the time to share it with us.
Thank you. Thank you very much.
All right.